I did a pain management fellowship which had an emergency medicine focus, and during my time rotating with different practitioners and specialties, I discovered there were quite a bit of alternative modalities, interventions, and medications that practitioners were doing in their offices or in the hospital that seemed applicable for emergency medicine pain management. After the fellowship, I worked with my chairman, Dr. Mark Rosenberg, to do some research into what conditions we may see in the emergency department that had some evidence for alternatives to opiates in treating pain. And we identified 5 conditions that had evidence in the literature where alternatives were as efficacious as opiates. So those conditions we identified were renal colic, musculoskeletal pain, lumbar radiculopathy, migraine headache, and extremity fracture dislocation. With some research and collaboration, we developed a protocol that we lovingly call ALTO, which stands for Alternatives to Opiates, and we've implemented algorithms for treatment of the 5 conditions using a variety of multimodal analgesia and interventions, all in an attempt to avoid opiates. The goal is not to avoid opiates for all conditions, and we are not anti-opiate, but the belief is opiates are not the first line for every condition. They should not be reflexively prescribed. Let's try and utilize alternatives whenever possible. And of course, we can always use opiates as a second line. It's really elevated our pain management in the emergency department. We're able to empower patients with a variety of options for pain management, including topical medication, pain patches, combining anti-inflammatories with acetaminophen. We're offering ultrasound-guided nerve blocks for extremity fracture or joint dislocation. We're also utilizing nitrous oxide in lieu of procedural sedation for pain management, which is fantastic because patients sometimes may have eaten or they may be trying to get to an event or work, and nitrous oxide doesn't have any NPO requirements. It is out of their system once we remove the mask, so it's a really effective analgesic anxiolytic. Additionally, we're using ketamine infusions and we're bolusing doses as well to deal with acute pain. So by using a variety of medications, we're able to tailor our pain management. And in patients who are recovering from opiate addiction or who would prefer to not use opiates, we now have many more tools in our toolbox to offer them that we know will be effective. Initially, when the program went live, there was a lot of focus on the idea that we were not giving opiates and maybe we were just giving Tylenol. And that was misinformation, and that was not the message we wanted to portray. But, you know, it's a good story, but that's really only a small part. Our goal is to utilize a variety of medications together to get effective pain relief, not sacrificing good pain management. And then as we got a little bit more attention, some media outlets like MSNBC or New York Times took an interest, and it was really wonderful to collaborate with the investigators to tell the whole story and to explain the comprehensive program we have that is obviously much more than just Tylenol. So media has been great because it's an effective way to get the message out to patients. We plan to publish and we plan to promote what we're doing in the medical literature, but also to help, again, empower patients to appreciate what else is out there for them with a focus on patient education. Of course, the media helps with that because it gives a lot of exposure nationally, which is great, to what we're doing, and we appreciate that attention and we appreciate the ability to spread the message.